We finished hypermobility disorders, ankylosis in detail. So today we will be discussing hypermobility disorders. So what is hypermobility? Excessive opening of the mouth or excessive movement of the temporomandibular joint. So hypermobility disorders mean excessive mobility. When applied to temporomandibular joint, it means hypertranslation. So in 1832, Sir Ashley Cooper proposed the principles for diagnosis and treatment of dislocation of the lower jaw. He introduced the term complete dislocation, luxation, and imperfect dislocation, subluxation. So these are all terminologies you should know associated with hypermobility. That is luxation, subluxation, and dislocation. So you will have an essay question on dislocation at times. So there are two essay questions from TMJ. One is TMJ ankylosis and surgical treatment. Second is hypomobility disorders, which is trismus, pseudoankylosis, false ankylosis, and true ankylosis. Your hypermobility disorders are luxation, subluxation, dislocation. And hypermobility disorders along with dislocation will be an essay question, and manual correction of dislocation. Ankylosis actually is not an emergency. It never happens in your chair side or on your clinic. But dislocation is not like that. It can happen anytime on your patient on the dental chair. So once it happens on the dental chair, it's a panic for both the patient and the operator or the dentist, because the patient can't close the mouth, it will remain open. So there will be so much of apprehension, anxiety, and you are in an emergency. You should know how to manage a dislocation. Understood? So ankylosis is a slow process which happens after trauma or your obstetric delivery, or so many etiologies there. Dislocation is something which can happen due to excessive mouth opening even on your dental chair. Understood? So it's an emergency and you should know to manage it manually. So hypermobility can be divided into three interrelated clinical entities: hypertranslation or hypermobility, subluxation, and dislocation. Now what is each terminology? Hypertranslation refers to excessive anterior movement of the condyle during opening. Normally the condyle translates to the inferior aspect of the articular eminence on full opening. It may be predisposing factor to subluxation, dislocation, or internal derangement. Treatment is seldom required for hypertranslation. Usually it is corrected itself by the patient. You don't need to intervene for a hypertranslation. The condyle is just getting out of the glenoid fossa and it comes back. So it is auto-corrected. You don't have to do any manual reduction for hypertranslation. Subluxation is defined as the displacement of the condyle out of the glenoid fossa and anterosuperior to the articular eminence, which can be reduced by the patient. This is again self-reduced. Patient can reduce himself or herself. Patient might usually complain of temporary inability to close the jaw completely. Subluxation can occur along with internal derangement. Here it occurs when the condyle translates over the posterior surface of the disc and comes to rest anterior to it. Treatment is not indicated in absence of pain. So for example, long dental procedures, you do a surgical removal of an impacted teeth or endo root canal treatment, anything which requires prolonged hours of mouth opening. So there will be a spasm of the masticatory muscles, and sometimes you end up in subluxation. But you don't have to worry about that. That is corrected automatically, or it is self-reduced. And what you can do for long procedures is, there is something known as, I don't know whether you have seen it, mouth prop. It comes in 3 sizes. There is a rubber mouth prop. So that you can use that to keep the mouth open. It is placed in between the maxillary and mandibular teeth, and the patient is asked to bite on that rubber mouth prop, so that the long hours of mouth spasm can be avoided. Understood? Okay. Now we'll look in detail regarding dislocation. This is your essay question. So dislocation is similar displacement of the condyle which cannot be self-reduced. So what is the difference between subluxation and dislocation, or luxation or hypertranslation and dislocation? Is hypertranslation is self-reduced or auto-corrected by the patient, but dislocation is similar displacement of the condyle which cannot be self-reduced. Dislocation might be acute or may be recurrent or habitual. The highest incidence of recurrent dislocation is among females. It's not because of females talking too much. The old saying is females will talk too much, but it's not because you are talking too much. It's the anatomy of the jaw and the TMJ which is creating. Usually the jaw size is not prominent in females compared to males. The anatomy of the mandible or maxilla usually is compared to the mandible size is usually more in males compared to females. That is the reason, not because you are talking too much. So the dislocation is caused by dysfunction of the TMJ, abnormal glenoid fossa, abnormal condylar head, relaxation of ligaments, relaxation of capsule, dysfunction of the muscles of mastication. These are the reasons. Now you can divide dislocation into acute and chronic, and treatment is different for both. Acute dislocation is caused by trauma, sudden movement as in singing or yawning, or as a result of excessive download pressure during extraction. What else you have excessive pressure? Vomiting. So singing, yawning, excessive downward pressure during extraction. So factors precipitating dislocation can be grouped into extrinsic and intrinsic factors. Extrinsic is from outside, intrinsic from inside. So extrinsic, overextension injuries, yawning, as I told you, vomiting, wide biting, seizure disorders. Wherever there are instances where you open the mouth in excess. That is why I told you 2 reasons in dentistry. That is your surgical removal of impacted, you have to open the mouth wide for long period. Your root canal treatment, posterior crown cutting or whatever, that is also an endo or prosto treatment. For all that, your impressions for your complete denture, wherever the patient has to open the mouth excessively. What are the extrinsic factors? Trauma, blow to the chin when mouth is wide open, husband hitting the wife, or wife hitting the husband, vice versa. When you are talking, somebody is hitting you. You are talking too much. So when blow to the chin, when mouth is wide open, manipulation of the, other than that, manipulation of the jaw during intubation, general anesthesia, your endoscopy, your gastroenterologist does an endoscopy. So for all that, you have to open the mouth wide. Tooth extractions. So this happens in a dental chair. That is why you should know how to manage it. It's an emergency. You can't tell the patient to go somewhere. Suppose you are practicing in a remote area. Some place like, what is that, Attapadi or somewhere you have a clinic. And the patient goes for dislocation. Where will you take the patient? Suddenly. Patient is open, mouth is open. You can't tell I'll take to Malappuram or Kozhikode. Till that the patient has to sit with the mouth open. Just imagine. So we need to know how to reduce it manually. Basics. Miscellaneous causes. These are rare. Internal derangement, occlusal discrepancies. You have a high point in your tooth filling. Occlusal discrepancies, or a faulty denture with no centric occlusion. Factors modifying dislocation. Some connective tissue diseases like Ehlers-Danlos syndrome, Marfan syndrome, psychogenic habitual dislocation, Parkinson disease. You have seen people with tremors in the hand or fingers or extremities, Parkinson's. Tardive orofacial dyskinesia and drug-induced your phenothiazines. Most of the epileptic drugs, anti-epileptic drugs can cause dislocation. So the signs and symptoms of acute and chronic dislocation are the same. There is no difference. Only thing is the treatment aspect is difficult. What you have to remember is when somebody asks you a question regarding treatment of acute and chronic dislocation, the more delayed the dislocation is not treated, it is more difficult to reduce it. So an acute dislocation can be reduced immediately. So if you don't know the manual method and you prolong the patient for 1 week or 2 weeks, it becomes more and more difficult to reduce the dislocation. So chronic dislocation is always difficult to treat compared to a acute dislocation. So what are the signs and symptoms of acute and chronic dislocation? Inability to close the mouth, preauricular depression of the skin. There will be a depression here. Pre means before the ear. Here. This is post, this is pre. Prominence of the condylar head anterior to the articular eminence. Elongated face. The vertical dimension of the face will increase because the mandible is out from the glenoid fossa. Excessive salivation. Patient is tensed, anxiety, salivation will be more. Patient can't swallow the swelling because the mouth is open, can't close the mouth. Tense, spasmodic muscles of mastication. Your masseter, vaccinator, temporalis, muscles of mastication, medial pterygoid, lateral pterygoid, all will be spasmodic. Severe pain of the temporomandibular joint, tenderness. When you palpate, there will be tenderness of the joint. Acute dislocation will produce damage to the disc, ligament and capsule. There is an inflammatory edema characterized by swelling, tenderness and increased temperature. In chronic dislocation, pain will be minimum and there won't be any swelling. Radiologic examination is essential to rule out associated condylar fracture prior to reduction. So a manual reduction, if not done properly for an acute dislocation, you may end up in a condylar fracture because you are forcing the mandible backward. So if you are not doing it in the right direction, you will end up in a condylar fracture. Understand? Stanley, mandible. Management. So treatment of mandibular dislocation depends on time elapsed between occurrence and treatment. The longer elapsed period indicates a difficult reduction. I told you, the more the dislocation is prolonged, treatment is difficult. In acute cases, immediate reduction should be done, and most often it will be adequate. In chronic and long-standing cases, other forms of surgical treatment are to be considered. That we will discuss later. But you, as a dental surgeon, you are supposed to know manual reduction of acute dislocation. That is mandatory. Understood? Because without that, you will be in trouble if you start your practice. Chronic dislocation is not your cup of tea. If you find it difficult, you can refer it to a maxillofacial surgeon or whatever it is. But acute dislocation, it happens in your dental chair, in your clinic. If you don't know how to manage it, you will be in trouble. Understood? Manual reduction will be complicated with difficulties because of anxiety, apprehension of the patient, and severe spasm of the masseter. So before attempting a manual reduction, you have to follow certain things. Before attempting reduction of the following measures are to be taken. Manual reduction. So your patient has a dislocated TMJ. You are reducing it in the dental chair. So first thing you have to do is reassure the patient. Tell the patient this is something transient or temporary. This is something which can be corrected. Ask the patient to open the mouth. So you can ask the patient to open the mouth wider. If the patient alone can do it, sometimes it gets auto-reduced or auto-corrected. So if a patient is panicked, all this is not possible. Understood? So you have to reassure the patient, try to ask the patient to open the mouth wider. Sometimes it might get auto-corrected. You can use mild sedatives like diazepam. That is to relax the spasm or relieve the spasm of the masticatory muscles, especially the masseter. Tranquilizers, again drugs. Massage over the coronoid and masseter. Again, all these are to relieve the spasmodic muscles, especially the masseteric muscle. Injection of local anesthetic to the joint for disruption of reflex, contraction reflex. This is something which has really good success. So if you can get your landmarks for your inferior alveolar block, which is conventional, which you do commonly, will be different in a patient with dislocation because the condyle is out. But still, if you can inject the local into the pterygomandibular space, you can get anesthesia. Thank you. But if you know some extraoral injection techniques, there are some extraoral techniques. If I am not wrong, some names, Gates or something like that, Vasarani, as you know, all those techniques. If you can use that, once local anesthesia goes inside the space, the patient is relieved of pain. So the patient will respond to you for a manual reduction, or the patient will themselves try for a manual reduction. Understood? So this local anesthetic is something which you have in your clinic and you can easily do it. But just follow these steps. Reassure the patient, asking the patient to open the mouth. All this can be done. Massage over the corner masseter. If you have emergency drugs in your clinic, you might even have diazepam or alprazolam. Any anti-anxiety drug you can give, and then try for a manual reduction. Now, how to do a manual reduction? Now, manual reduction. So this is done by standing in front of the patient. You have to seat the patient upright in the dental chair. Raise the dental chair. Keep the chair upright. Like how you take impression for your denture, you keep the maxillary arch, you take impression, you keep the chair upright. Don't keep the chair like this. Should be upright. You stand in front of the patient. Patient is firmly seated and head supported. Head support should be there. When you do a reduction, the head should not move here and there. If you have a dental assistant, ask the assistant to hold the temporal region of the head so that it doesn't shake. Understood? Thumbs wrapped with gauze and placed over the occlusal surface of the mandibular molar teeth or alveolar ridge. Why thumbs should be wrapped? You have put a gloves. You wrap your thumb. If at all, when you use force, patient has some sharp teeth or something, your hand should not be injured because you have to use excessive force. You can use a gauze to wrap the thumb. The lower aspect of the chin is grasped with fingers. So, see, thumb on the occlusal surface, lower mandible is grasped with your fingers. You should get a firm grip. You can use both the index and the next finger. Patient is encouraged to relax. Patient should not sit like that. The muscle should not be twitched. Then you won't be able to force reduction. Ask the patient to relax. That is why the local anesthesia is necessary. If you give local anesthesia or if you give diazepam, the patient will be relaxed. The patient is encouraged to relax and open in the direction of dislocation. If already dislocated, you should ask the patient to open against the dislocation force with you holding like that. The condyle is depressed by pressing down. See, the condyle has come out of the glenoid fossa. So you have to press the mandible down first. Downward with the hands on the molar, downward, and simultaneously elevation of the anterior region with fingers. So it should be downward and backward and up. With the fingers, rotate the condyle over the articular eminence into the fossa. So you just imagine the anatomy. The condyle has come out of the glenoid fossa. So when you reduce your thumbs on the occlusal surface of the mandible, your fingers firm grasp on the inferior border of the mandible, downwards, backwards and upwards. This is how you do a mandible reduction. So if you look at the anatomy, the condyle, this is the glenoid fossa. Suppose this is the glenoid fossa, like this. It has come out like this. So downward, backward and upward. Just to go back. Understood? This is how you do a manual reduction. Now the difficulty encountered with treating mandibular dislocation increases with the duration of dislocation. I told you before. In long-standing cases, the dislocated condyle would have undergone fibrous adhesions to the disc and articular eminence. The jaw muscles would also have undergone fibrotic changes. These prevent non-surgical methods of reduction. In such cases, the modalities of management include manual reduction under general anesthesia and muscle relaxation. Suppose your patient is not relaxed and this after some 2-3 attempts you fail, you can't do a manual reduction, don't force reduction. If the patient is not relaxed and is with a spasmed muscle, if you try manual reduction, you might end up in a condylar fracture or subcondylar fracture. The condylar neck is very thin. If you use too much of force, the condyle will fracture. So such patients, even after your assurance and your muscle your local anesthesia, all these things, the patient is not relaxed, you have to refer the patient to a hospital where you can do a manual reduction under general anesthesia and injectable parenteral muscle relaxants. Using functional appliance. This is for chronic dislocations. Using class 3 elastics. What does a class 3 elastic do? Pull the mandible backward. So you fix a tube or bracket in the posterior teeth, maxillary teeth, molars, and you put an elastic to the canine, anterior canine. That is how you put a class 3. Class 3 is like this, class 2 is like this. Class 3 always pushes the mandible backward. And then surgical methods. You have to open the TMJ. That is a very difficult surgery. TMJ surgery is always difficult and with a lot of complications. When you open, the approaches of the TMJ, only if you are not careful, can lead to facial palsy, damage to the nerves, branches of the facial nerve. So maximum you should try for a manual reduction. Only if these methods are not possible, you should attempt a surgical reduction. Understood? Now what are the surgical methods? Suppose it's a chronic dislocation where you can't correct manually. Electively you are going to correct it under general anesthesia using surgical methods. Open technique. Here wires are hooked around the sigmoid notch and the condyle is distracted inferiorly and condyle is repositioned into the fossa. In case of fiberoptic temporalis coronoidectomy, aids in repositioning of the condyle. So you have to shave the coronoid, that is known as the coronoidectomy. So in some cases, temporalis coronoidectomy will aid in repositioning the condyle. Other procedures are condylectomy, again shaving the condyle, eminectomy, shaving the articular eminence, and sagittal split osteotomy. That is an orthognathic procedure. It's a aesthetic surgery procedure of the mandible, usually for correction of protrusion or retrusion of the mandible. That anyway we will come to that in the facial aesthetic surgery class. So these are the surgical methods. How you manage chronic recurrent dislocation? Management of cases with chronic persistent dislocation is troublesome. These are ideally managed by surgical methods. Before initiating surgical intervention, all reversible etiologic causes should be investigated and possible psychological factors evaluated. Many procedures have been devised to manage this problem. Surgical procedures for correction of recurrent dislocation can be divided into three types. Those that remove the blocking factor of the path of the condyles. If there is any blockage which hinders the movement of the condyle. Those that limit the range of motion. Those that alter muscle balance. So you have to look into these three factors before planning a surgical correction of recurrent dislocation. So that is it. So usually you don't get a question on surgical correction of dislocation, but you get a question 100% on manual correction, reduction of dislocation. So with this class we conclude TMJ disorders: hypermobility, hypomobility, ankylosis, dislocation. Thank you.